Hey, happy Tuesday. I'm excited about this one. Today we're talking about direct contracts and why direct contracting is back. So, somewhere in your vendor contracts, your PBM contract, your carrier agreement, your TPA, there are two words that explain everything we've covered in this series. Managed to contract. It means your vendor is optimizing for what the contract allows, not for what's in your best interest. The contract is the ceiling. And if the ceiling permits spread pricing, rebate retention, and all of those phantom savings, then all of that is working exactly as designed. Today, we're going to talk about what employers can do instead. It's called direct contracting. It's not new. It's basically what's left when you stop pretending the standard model is working. I really do believe direct contracting is the future. I have seen the money that it saves firsthand. And I think we're pretty much getting to the point where we're not going to have another choice. So let's talk about it. Managed to contract isn't cynical shorthand, it's how these vendors actually operate internally. Their incentive system is built around contract compliance, not plan performance. Your PBM is not trying to reduce your drug spend. They are trying to stay within the terms of what you agreed to. Your carrier isn't trying to minimize your total cost of claims. They're managing to what the contract permits. This really matters because it totally reframes the question employers should be asking at renewal. Most employers ask, are we getting a good deal on this contract? Stop asking that. The better question is, does this contract structure incentivize the vendor to reduce our total cost? Or does it incentivize them to extract margin from the plan? How are they getting paid? Those are different questions and they produce different contracts. Direct contracting is the structural answer. Instead of going through a carrier that profits from the spread between your costs and the provider's reimbursement, you contract directly with the health systems, the surgery centers, the high value provider networks. It's always a better experience and the cost is so much less. Doctors love it too. Doctors don't want to deal with insurance. Doctors hate insurance. This way, they are guaranteed a set payment and it's pretty quick. They don't have to wait on the insurance lag and they don't have to wait to guess to see how much they're going to be reimbursed. All right, so 3 pillars. The first one we covered quite a bit, predictable costs, bundled case rates. You know what a knee replacement costs before it happens. Number 2, better accountability. Contracts are tied to outcomes, readmissions, complications, not just volume. And then number 3, aligned incentives, savings that are shared with providers who deliver them, not extracted by useless intermediaries. Get out of here, guys. Roughly 75% of large employers are doing some sort of version of this today, but the ones that are getting the best results aren't just picking better vendors, they're writing better contracts. One of the main reasons why I came to Hotchkiss was because this brokerage firm really thinks outside of the box. They're 10 to 15 years ahead of the standard market. And I really do think direct contracting is going to be the future of benefits. Spread pricing, rebate retention, out of network repricing fees, managed to contract. None of these are loopholes. None of them are accidents. They're features of a system designed to be opaque, and they stay in place because most employers never read the contract closely enough to understand what they've agreed to. And honestly, they shouldn't have to. That's your broker's job. The companies winning on benefits right now have one thing in common. They treat the contract as a financial document, not some sort of administrative formality. It is a legal and financial document, so they need to have their legal and their finance teams review it. Negotiate the structure, not just the rates. That's the past 4 episodes in one sentence. Read the contract, then fix the structure. If you've been watching and want to know what to do next, the answer is your PBM contract. Pull it, find the rebate pass-through language, find the audit rights section, and then find out if there's any fiduciary language in there at all. If you want help with what you're reading, that's what I do. Please feel free to reach out. All 4 articles are on my blog, insideyourhealthplan.com. See you next week.